Good afternoon, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Welcome to today's international guest lecture, which is held by the Department of Nutrition and Health, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. We are delighted to have you all here, our respected lecturers, clinical instructors, also students, and of course, our distinguished guest speakers from the Department of Dietetics, Faculty of Medicine and Health Sciences, University Putra, Malaysia, who will share valuable insights on current issues of food service management and recipe development for improving food quality. My name is Umi Salama and I'm honored to be your Master of Ceremony who will guide you through our program today. Before we begin, we would like to remind everyone to keep your microphones muted during the presentations and feel free to drop your question in the Zoom chat for the Q&A session later on. Ladies and gentlemen, formally begin this event, I would like to invite the head of the Bachelor in Nutrition of the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Ibu Erdwi Budiningsari, PhD, to deliver her opening remarks. Ibu Budiningsari, yours.
Ya, thank you very much, Mbak Umi. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
afternoon.
warahmatullahi wabarakatuh.
Good afternoon to our distinguished guest speakers, Dr. Noraida Omar and Dr. Syafiqah Rahamat from Department of Dietetics, Faculty of Medicine and Health Science, University Putra, Malaysia, and also for our undergraduate students, lecturers, then practitioners from the food service management fields, such as from hospitals and also catering. On behalf of the head of Department of Health Nutrition, Faculty of Medicine, Public Health and Nursing, Gadjah Mada University, allow me to express great pleasure to extend you the very warm welcome to say how grateful we are to our honorable international guest speakers to share expertise and experiences in this virtual international guest lecture on the topic, the current issues of nutrition management in food service and recipe development for improving quality. The increasing trend of away from home meals is highlight the importance of food service management. The role of nutritionists or dietitians is different depend on the food service models and the requirements by the consumers and also institutions. The balance between cost, sustainability, and food service provided should always be centered in the improvements of patients' satisfaction and also support and for all clients. In addition, there is an increasing demand for greater attention to the environmental impact of the food production in all food service settings. There are factors that are likely to have increasing concerns with a demand for the use of more local foods, recycling, and improved energy efficiency. Furthermore, recipe development is important to improve food quality in hospitals and also in other institutional food service settings, including commercials. So we are excited to learn from Dr. Aida and Dr. Syafiqah to develop recipes in Malaysia. For all of us as an academicians, students, and also practitioners, it is necessary to broaden the current information and latest scientific knowledge of nutrition management in food services to prepare the challenging roles of future nutritionists or dietitians professionals. We are very much thankful and appreciations to our guest speakers, all of participants, and in concluding, I wish you a fruitful guest lecture and hopefully possibility of other collaborations in the near future. Thank you very much. Kak Umi.
Thank you, Ibu Budiningsari, for the warm and inspiring opening. Now we will proceed to the highlight of today's event, lecture session. It is our honor to welcome two esteemed speakers from the Department of Dietetics, Faculty of Medicine and Health Sciences, University Putra, Malaysia, Dr. Noraida Omar, and also Dr. Syafiqah Rahamat. And then to moderate this session, we're also joined by our beloved lecturer, Miss Marina Hardianti, Master of Science. Without further ado, I now hand over the session to Miss Marina. Miss Marina, the screen is yours.
All right, thank you Mbak Umi, and also thank you Bu Nuning for the welcoming speech. Selamat sore Bapak Ibu semuanya. So today's lecture will be delivered in bilingual, so bahasa Indonesia and English. Before we start our lectures, I would like to thanks and also welcome all of the audience. This lecture is meant for the third year, semester 6 of Bachelor Nutrition program, but also it is open for clinical instructor and also students from year 2, year 1, or year 4 to join. So very welcome to all the CI, kepada Bapak Ibu pembimbing PKL, kemudian juga Bapak Ibu mitra Departemen Gizi Kesehatan dan teman-teman mahasiswa semester 1 sampai semester 8 yang ikut bergabung pada lecture kali ini. Terima kasih sudah bergabung. So the topic for this lecture is current issues of food service management and risk development for improving food quality. Kita akan mendengar 2 sesi lecture. Yang pertama nanti dari Dr. Noraida Omar, kemudian yang kedua dari Dr. Syafiqah. Untuk yang ingin bertanya nanti boleh mengajukan pertanyaan melalui chat, boleh dalam bahasa Indonesia, boleh dalam bahasa Inggris. Sebelum kita membuka sesi kuliah ini, saya akan memperkenalkan terlebih dahulu speaker kita. Yang pertama adalah Dr. Noraida Omar. So Dr. Noraida finished her bachelor degree in dietetics program, University Kebangsaan Malaysia, and got her PhD from University of Surrey, UK, the specialization in nutritional science, dietetics. She has been teaching in UPM since 2007 until present, and also actively participated as a member in Malaysian Society of Body Composition, Malaysian Dietary Guideline for Older Adults, Malaysian Dietetic Association, and a dietitian in Clinic Diet FMC and Clinic Diet Warga Emas. Dr. Noraida received so many achievements in research field, including scholarship and research grant. And several of her research areas are institutional food service, especially in hospital food service, malnutrition management among geriatric patients, healthy eating and active lifestyle. And for the second speaker is Dr. Syafiqah, whom also senior lecturer and researcher in the same department as Dr. Aida. So Dr. Syafiqah got her bachelor and master from University Teknologi Mada, Malaysia in food service management program. She finished her PhD study from Iowa State University, United States, with the specialization in hospitality management. And Dr. Syafiqah also has been teaching in UPM since 2020 to present. Her research area and publication are mainly about food labeling, consumer behavior, food choices, food safety, and food service management. So we are really looking forward to listen to the lectures by Dr. Noraida and Dr. Syafiqah. So for the first lecture will be delivered by Dr. Noraida Omar. So the time is yours, Dr. Noraida.
All right. Thank you so much, Ibu Marina. Can you hear me well? Yeah,
Very
okay.
well, very well.
Okay. Hello and Assalamualaikum to all participants of today, especially our third year nutrition student, the clinical educator, all the academics, and also we also have the practitioners from the nutrition field and also food service. Yeah. Thank you so much, UGM, Ibu Nuning, Ibu Susi, Ibu Marina for this collaboration. So I think this is our continuation of collaboration in delivering lecture on the specific topic, yeah, current issue of nutrition management in hospital food service and also recipe development for improving food and quality in hospital. Okay, so we have two speakers today, me and my colleague Dr. Syafiqah. I will focusing on the hospital food service, and Dr. Syafiqah will focus on commercialize. Okay, how to wait, yeah. Okay, guys. Sekejap, tak moving pula.
I think you need to
Ya,
share
Ibu,
entire screen, Dr. Aida.
share entire screen.
Yes.
Okay. Okay. All right. Thank you so much, Dr. Syafiqah. Okay, this is about my something about me. Okay, I'm Noraida Omar. Call me Dr. Aida. My expertise is focusing on the clinical geriatric nutrition and institutional food service management. And this is my contact. So my research, as Ibu Marina already mentioned, my research and also teaching focusing on clinical geriatric nutrition and also institutional food service management. So this is our learning objective for today's session. So first is to discuss on the current challenges in hospital nutrition management, and also this is the very important to explore the strategy for recipe improvement to enhance food quality in the hospital setting. So some revision on the food service industry. Okay, so in your lecture, I believe you already learned about food service industry. We have two types. One is the non-commercial. The primary goal for the non-commercial is to provide services. Then comes in hospital, education, government, and also military. And the second one, so this one will be given by Dr. Syafiqah later on. So primary goal for the commercialized is to generate income. For example, for the commercialized food service industry is the restaurants, hotel, in coffee shop, fast food restaurants, the convenience store, daily snack bars, and other retail food establishment. I hope at this stage you know the differences, how to differentiate between non-commercial and also commercial. Okay, so some revision on the food service system model. Okay, so food service system model, you need to understand that this food service system model is really important. If you know about this fundamental, you will understand on overall of the food service system, either commercialized and non-commercialized. It start with the input start with the human, material, facility, and operational, and then input transform to the output. Okay, this is the output that we want to learn today, how to improve the food quality. When we mention about the output, so we need to preset what actually the quality that we want, the quantity. And when we produce food, we want to ensure that our customer, our patient, our children, our student is actually satisfied, our employee also satisfied, and also the food that we produce is within our budget. And then the circle is actually going up again to the input, and then for each cycle, actually, you will receive feedback. That's why really important to conduct the audit, the clinical audit, so that you have received the feedback to improve the next cycle. Okay, and then to understand about everything, every food service system model is controlled by control. So that comes what actually your goal, objective, what actually the policy and procedure, the standard, the contract, the law, and also the regulation. We also need to understand in this food service system model, this is the open system whereby it will interact the environment factor. Okay, so some of the environmental factor that will impact or change the food service system model, for example, is the technology, the temperature, the weather, okay, the politics, okay, the persaingan, the competitors also will affect the overall food service system model. Okay, so I hope you understand about this food service system model before you start commercialized or non-commercialized. This is the model that you need to understand. When we talk about the hospital, food service in hospital, you should know about the importance of the hospital diet. So hospital diet really important. It's actually a part of the recovery process of the patient. Okay, so to maintain patient nutritional status comes the role of the proper good quality of hospital diet throughout the hospital stay. So hospital food is actually primary and also the sole source of the nutrition for more than 75% of the hospitalized patient. Why 75%? Is another 25% whereby patient on enteral feeding, on parenteral feeding, okay, that not require hospital diet. And then if patient satisfied with the hospital diet, it actually will happy throughout the hospital stay, because satisfaction is food is verbalized by patient. Yeah? Sedap tak sedap, right? And patient satisfaction actually will lead to the overall clinical outcome. Okay, so patient satisfaction actually is part of the audit, clinical audit in the hospital that you need to do every cycle so that you know which benchmark that you actually in. Okay, so this is the characteristic of the hospital diet. So hospital diet must be flexible to cover several requirements. In the hospital, we have the pediatric cases, we have the older patient, we have the adults, we have a patient with the multiple disease that different in the metabolic and catabolism state. You need to understand about the clinical condition, the age range, the social diversity. They are B40 patient, they have M40, they have T20, how to generalize for all socio-economic status. You need to understand about the culture and also religion background to build the menu, the recipe. You actually need to understand to which population that you are covering. Okay, so apart from that, hospital diet must be attractive in the sensory evaluation. It must be taste good. It must well presented. It must suit the preference of our patient. Okay, it must serve with the high quality. If you refer to the food service system model, one of the component of the output is the quality. To retain the quality of the output, you need to ensure that you actually provide the good material. You need to ensure that the food that you serve, that you produce, are actually safe to consume. Okay, hygiene, okay, and also meeting the nutritional requirement of the patient. And lastly, very important, within the allocated budget. So if you understand that the food service in the hospital is the non-commercial, the aim for the service is to provide the services rather than to generate the income. Okay, so within the allocated okay, so this is the current trend. If you manage the hospital food service, we have our key reference. Okay, in Malaysia, we have Manual Diet Hospital 2016. So this is the latest and the one still active using by our government hospital as well as our private hospital as a guide. But when the hospital use the outsource company, for example, here for hospital UPM, previously we are with Mas Awana, or currently we are now with the Sriza. So both company will produce their own hospital diet manual. Okay, as a key reference to all chef, to all dietitian, to to build the recipe, to build the menu, okay, that meeting the requirement of the patient. So this is the type of hospital diet. Okay, a patient in the hospital not only giving the normal diet, but they also the therapeutic diet. We have the low residue diet, diabetic diet, soft diet. We have the diabetic vegetarian. We have low fat, low sodium diet. We have high protein diet. Okay, we also have the pediatric diet. Every type of the hospital diet comes with their own characteristic. That dietitian must know the key differences about these three therapeutic diet as compared to the normal diet. Apart from this, we also have therapeutic diet that manage the texture. That's suitable for the older patient, suitable for the pediatric, suitable for the patient with the dysphagia. That's one is a texture modified diet. Okay, so this is the food chains in the hospital. Start with patient in the ward, and then they ordered the meal, and then the meal we produce in meal in the hospital consists of the carbohydrate, protein, vegetarian, and fruits, and it comes with the dessert as well, and then they distribute in the kitchen, and then transport to the ward, right? And then either in the hospital they use the centralized system, and then they will meal will serve to the patient, and then the meal tray and will collect and clean by the kitchen. Okay, either we have the centralized, hybrid, or decentralized. The mechanism actually similar, but when it comes to the how to distribute, it will make a differences. Centralized is we have a centralized kitchen to do the plating before go to the ward. Okay, or decentralized, meaning by the meal from the kitchen is bring to the ward, and they do the plating in the pantry ward before they serve to the patient. Okay, so this is the meal ordering system. Okay, depending to the hospital, whereby they use the online system. For example, e-dietary, okay, or iServe, e-sajian, TIS, HIS, system sajian, and bed watcher. Or they use a manual meal ordering system, whereby the nurse take the order from the patient and manually fill the order form and submit to the kitchen. Or hybrid, meaning that they use both manual and then online. It depends to the hospital practices. But in the hospital UPM, we use the online e-dietary. Okay. So meal distribution system, this is what I said before, is about what happened after food being produced in the kitchen. If they use the centralized, meaning that food after produced by kitchen in the tray line, they will prepare and assemble to the individual tray before they transport to the ward. Or decentralized, meaning that food that had already produced in the kitchen and then transport to the ward, and then at the ward they use pantry or any location that near to the patient, and then they do the plating and then straightly serve to the patient. Or maybe they use hybrid. Okay, or each ward, maybe they differentiate between, okay, this ward they use the centralized, and this ward they use the decentralized, depending on the need of the hospital. Okay, so food service operation in Ministry of Health Malaysia, we have two types. One is the in-house operator, meaning that in that hospital, in that facility, they have appointed the government staff as a cook or food service officer or dietitian to run the food service in the hospital. Okay, or they use the outsource operator. This one is a new trend, meaning that the facility is run by the food service company appointed by Ministry of Health through the contract basis. So current trend, 10 hospital in Malaysia, okay, with the outsource operator, but I believe now the numbers is keep on increasing. Okay, especially hospital, private, that nowadays the growth is very high. Okay, but with the minimal area of the kitchen, so they opt for the outsourced operator. Okay, so apart from the outsourced company, this is the current or future trend. We focus on the food safety, HACCP, halal, the GMP, and all the accreditation. Okay, now food service operation for the commercial, for the outsourced company, they have their own centralized kitchen. When they have the centralized kitchen outside the hospital, now is the time for the growth for the cook serve, cook chill, cook freeze. Okay, and then the sustainability, very very important now. So current issue. So current issue in the nutrition management in the hospital. What actually the issue that bring to the concern why our food service management cannot give well, because we are very depending on the budget and cost control. We have the staffing shortage and skill gaps. We have the higher turnover rate of our food service staff that requires more training. All right. So food service staff requires training, but they have the higher turnover rate, whereby we need to retrain the staff. It actually the waste and higher cost to the hospital itself. Okay, so requires menu standardization and personalization. Okay, so nutrition adequacy and patient specific needs. This is the very very important, because if patient not meeting their adequacy, meaning that patient actually not eating well in the hospital, higher plate waste. We will focus on this later. And then monitoring and compliant with the clinical diet. Okay, because in Malaysia we don't have the policy no outside food. We need to build on the awareness to the patient and also to the caregiver. So not to bring the outside food or home cooked food in the hospitalized setting. We need to ensure that our patient is actually eating the hospital diet. So this is the current issue. Okay, so this is the thing that I would like to bring to the attention. Okay, hospital food waste. It's very high now. Internationally, data is up to 65. But in the Malaysia, focusing on the therapeutic diet. Therapeutic diet meaning that patient on diabetic diet, low fat diet, low salt diet. Okay, that one can be up to 79%. Okay, so we talk about hospital that use the outsourced company. The plate waste is actually about 35. Okay, and about 66% of the patient that having the higher nutrition risk is actually consume less portion of meal, and that wasted significantly higher amount of food. Okay, so to ensure you know which is the benchmark, you need to understand that acceptable food waste is around 10 to 30% only, and the mark now is 65 or 80% for the therapeutic diet. What happens if the hospital food waste is continuously high? It will lead to dissatisfaction to all the hospital staff. The cost will be more higher because the food is being wasted. Food is actually a cost. And also if need to compensate the nutritional adequacy to patient, then we introduce the commercialized food, the enteral food, the oral nutrition food that costs more to the patient, more to the government. Okay, so now you know acceptable food waste is around 10 to 30%, and now the figure is up to 80% for the therapeutic diet. So this is the factor leading to the food waste. If we refer to meal distribution system, hybrid system, is actually give the higher wastage, whereby the hospital use centralized and decentralized food service system, higher 64%. So hospital that use the manual form, higher percentage. Okay. Factors associated with the food waste. This one, outsourced food service operator give higher food waste is about 60%. So which food source that lead to higher waste is vegetable food, that give the highest waste. And also therapeutic diet. Patient will waste more if patient on therapeutic diet as compared to the normal diet. Okay. All right. So for why in-house decentralized have lower right, lower food waste, because they are satisfied more with the quality. Okay, because the process of delivering food from the kitchen to the ward is more fast, okay, compared to centralized, whereby all the process of the plating need to settle first in the kitchen level, and then when the time is higher, the temperature of food also will reduce. So that's why patient is actually more satisfied with the decentralized. Okay, so when we talk about food waste, okay, food waste not only happen in ward, whereby patient not eating or more than half, okay, but it also happen when the staff make a excess order in the purchasing. All right, producing meal production and distribution, and also meal served to patient. Okay. So the consequences of the poor nutrition, it will leads to the malnutrition. If patient having malnutrition, it will leads to more complication, whereby patient have a delayed wound healing, increase the infection, delay the patient recovery, prolong the hospital stay, increase the cost, increase the environment cost, reduce the quality of life, and also increase the morbidity and also mortality. So this is the strategy to reduce the plate waste. One of example is when to monitor the temperature, we use the insulted trolley. This one's really expensive. The price is similar to the car, okay, in Malaysia. Okay, protected mealtime. UK already use the protected mealtime, especially to the older adults. Okay, mealtime assistant. Okay, it's very hard to implement in Malaysia because we have a very limited staff. Okay, cook serve. Some hospital we use the cook serve because by using the cook serve, we can maintain the quality. We use the standardized recipe and portion size. Okay, a good forecasting and meal ordering system to avoid over or under produce of food, and also room service, whereby patients are really satisfied with the quality of food that's served using the room service. Okay, so this is the role of dietitian in the hospitals. Apart from doing the nutrition assessment, we also do the nutrition care process. We collaborate with the kitchen. We do the staff training, and you do the frequent menu audit, yeah, and also we advocate the patient-centered meal service. Okay, but this one is very important, but requires more budget. Okay, for this. Okay, so this is the second topic for today: recipe development. When we talk about recipe is actually very important tools, okay, to communicate. It's actually a written communication that leads the food service staff to start the preparation, especially to prepare the ingredient and also to prepare the scheduling of the employee. It's actually a quality and quantity control tools, but the more important now is a recipe standardization. To develop the recipe, you need to ensure that the recipe is standardized. To standardize recipe is required repeating testing that consistently deliver the same quality and also quantity if you produce by other person. Okay, regardless who actually produce the food, but if they use the standardized recipe, the quality and quantity of the food can be retained. Okay, so kenapa a standardized recipe really important, because it will lead to the consistency. For the sensory evaluation, the flavor, texture, the portion size, but more importantly is the nutrition composition for each menu. It also support the therapeutic goal, whereby patient on the low sodium, high protein, while using the standardized recipe, we also can reduce the plate waste and also simplify the function of the food service operation. We also can minimize the effect of the employee turnover. As I mentioned earlier, one of the issue now, employee turnover very fast. Okay, so by having the standardized recipe, we can minimize the effect because we already have the tool. Okay. All right, so to standardize the recipe, okay, we actually need the recipe, okay, and then after we choose the recipe that's suitable, that meeting our objective, our population, okay, and then we need to evaluate the product, okay. After we evaluate the product, and then we adjust according to the quantity that we required. And then the cycle need to run at least 2 or 3 times before we standardize. We make it standardized, meaning that we happy with the output that we receive from the standardized. Okay, so to measure the success, while we do the recipe development, so if we're not doing any audit, it actually macam seronok sendiri. Okay, so we need to ensure that the clinical audit is run on the regular interval so that we are actually on track. One of the component to measuring the success is by using the patient satisfaction survey, food waste tracking. Okay, we have several methods to track the food waste. We use the nutrient analysis before and after modification to meet the nutrition requirement of the patient. And this is the most important thing, by look at the patient clinical outcome, whereby patient improve on the weight, for example, because weight is very easy to measure. Or if our outcome is to measure the increment of the muscle, okay, so that will be part of the assessment as well. So as a moving forward, okay, to ensure that our work is in the good track, so we need to embrace the innovation and also still using the evidence-based practice guideline. We enhance the interdisciplinary collaboration. We as a dietitian, we're not working alone. We work as a team, especially with the nurses in the hospital, in the ward, whereby nurses play a very crucial role to identify which patient who are higher risk, okay, based on the meal that we serve. For example, if patient for the 3 consecutive meal have left the food uneaten, more than half, okay, then it's role of the nurse to notify the dietitian so that we can make intervention for the patient. Okay, so integrate a feedback loop from patient. We want to have a two-way of the communication, always ask feedback from the patient, okay, and also advocate for the sustainable food service practices. Okay. Okay, that's all from me for this moment. I'm open for Q&A after the slot from Dr. Syafiqah. Yeah. Thank you, Ibu Marina. Over to you. I hope I finish within the time.
All right, thank you, Dr. Aida. It's really on time.
Okay.
So thank you so much. All right, thank you, Dr. Aida, for really clear and insightful session. And we got so many new information and knowledge for our students and also for our audience. So everyone, you can ask Dr. Aida for any questions regarding the topic. You can write down at the chat box. It's okay in Bahasa or maybe in English, but we will discuss after the lecture from the Dr. Syafiqah. So we will continue the lecture with Dr. Syafiqah. So Dr. Syafiqah, the time is yours.
Okay, thank you, Miss Marina. I will share my screen.
Have you already? Yeah, it's processing.
Processing. All right. Is it move? The slide?
Still processing. Yeah, it's
Okay.
already. Yeah.
Assalamualaikum and very good afternoon. I think it is evening. Okay, evening already. First of all, I would like to thank Dr. Aida. Now I proceed with my topics, which is current issues in commercial food service and recipe development to improve food quality. So my focus is on commercial food service. And thank you for UGM for inviting me again to share some information regarding the food service. I'm happy to do that, and I hope at the end of my lecture, you will get something new or some information that useful for you. Okay. Before I proceed, I would like to give some background of me. I'm Syafiqah Rahamat. I'm teaching in UPM and my background food service, and currently I'm teaching food service management for student in nutrition as well as dietetics. Okay, here are the outline of my lecture. A little bit different with Dr. Aida, the approach. I will highlight the issue first, followed by recipe development in commercial food service, and then I will conclude my lecture at the end of this presentation. Okay. Now, let's begin with the issue in commercial food service. I think you already know what is a food service, right? Because I think Dr. Noraida already highlight and you already learned in your classes before this session. So food service is the prepared way from home that delivered to the consumer ready to eat. It can be commercialized, which is profitable, or it can be institutional food service, right? So again, commercialized food service is based on profit. Example of a commercial food service is include restaurants, hotel restaurant, cruise ship, sport events, convenience store, airport restaurants, country club restaurant, museums, and so on. Now, let's take one step back. Ask yourself, why is the commercial food service industry is important? And or maybe we can say why food service industry is important. Okay, one of it because the economy. This one I got from Central Statistic Bureau of Indonesia and published by CRIF. Okay, if you notice here, food and beverages industry in Indonesia play a bigger role in terms of GDP. Can you imagine, compared to the education services, land transportation, food and beverages industry, bigger than that? And food service industry itself in Indonesia is also bigger, okay? Which is, this has been published in USDA in 2022. The food service sector in Indonesia contribute 23 billion USD in 2021. And I believe these numbers are bigger now because remember, in 2021, we are just hit by the pandemic. So can you imagine the post-pandemic, this industry is growing. But this industry also have issues, okay? One of the big concern or big issues in industry in this industry is the public health and nutrition issue, which is many studies highlighted food that serve in food service industry are commonly a poor quality diet or high in fat, high in sugar, which lead to the significant increase and cause concern on public health, especially NCDs. So, what we need to do by this issue? Do we need to just let it go or ignore it, or we can do something? Actually, there are many things in food service operation or in food service industry. There are many interventions, there are many things they do to help consumer to stay healthy when they eating out or they obtain food from food service. One of it is using menu labeling. So what is the menu labeling? Menu labeling is a list of calories or other nutrients posted on menu. For example, in this picture, if you can see, like burgers, on the menu, they put the name of the item as well as the calorie count. So that when consumer or customer go to the restaurant, when they want to order, they will get this information before they make decision. So they know which menu item have lesser calorie as compared to others. Because currently, I'm not sure in Indonesia, but in Malaysia, they are not mandatory to have this calorie information on the menu in the restaurant, but certain food service operation, especially the chain restaurants, for example, KFC, McDonald's, this chain restaurant provide this information. Okay. And this is the example of menu labeling in Canada, right? And based on several studies, and I also conducted study to see the perception of customer in Malaysia about menu labeling. So most of them perceive providing nutrition information or menu labeling in restaurant is important. Customer also believe restaurants should accurately tell nutrition information on their menu. And surprisingly, they also like to see additional nutrition information. For example, sugar information, other nutrient information such as sodium and so on. And they said if this information available in food service, they intend to use it. So from customer point of view, they are waiting for it. They look for menu labeling in a restaurant. This is another research I conducted. This one I conducted with my team in USA among students, among university students. We also find similar results, which students in university also plan to use menu labeling if it available in on-campus food service operation. Okay, next we go to the second issues in food service, especially commercial food service, is rising food costs and supply disruption. Why food cost is rising? Because the ingredient that we buy is keep increasing in terms of their prices. So in this picture, I believe you learn about this in your in food service courses or other food system courses. These are simple, the simplified of the food chain or food system. We get our ingredient either from the farmer, or we can buy from the processor, or we buy from the vendor or the supplier. It's very easy and very straightforward. But these days, this system, these change are disrupted by many factors. For example, war, geopolitics, climate changes like flooding, and so on. Okay, I would like you to see this. I believe all of you know about this. Sorry, I tak boleh tanya soalan because I cannot see how many of you put up your hand. But I believe some of you or many of you have this tempeh today during your lunch or maybe during the dinner later. But do you know where you get the ingredients to make a tempeh? The main ingredient to make a tempeh, the soybean, right? Or you call it, if I'm not mistaken, you call it as kacang kedelai. Okay, I hope I correct. You say it, but it's a soybean. Okay, tempeh and soybean tariff disruption. Do you know what happened if the trade war between US and China keep happen? It maybe inflate the price of soybean. Not only price, maybe Indonesia may have faced the what we call shortage in the supplying soybean. Now ask yourself, where will the food service operators will get the soybean to make a tempeh in short time? The answer, the small tempeh producer will hit by this disruption. And maybe you are no longer see tempeh, the original tempeh using soybean on the menu. So these are one of example or close example for you to see how important, how the disruption of the supply chain will affect or give a big issue in food service. This only tempeh, there are a lot more. Even in Malaysia, for example, during the COVID-19, we have a shortage in our onion because we got our onion from India. And recently, because of war between Ukraine and Russia, we also, around the world, not only us, around the world, face a shortage in terms of our supply for tepung terigu or wheat flour. So these are the things usually students or nutritionists or dietitians, they didn't see this. And actually, this is very important to know the sources where we get our ingredients, because there are many issues related to our sources. And this issue will affect the offering of the menu to our customers, as well as to develop the recipe. All right. Third issue is a labor shortage. And these issues not only happen in commercial food services, but also in institutional food service. If Dr. Aida said in institutional food service, they also have these labor shortages. In commercial food service, you can see it clearly because you will experience this every time you go to the restaurant or food services. And I believe even in the warung, nowadays they use QR code, online payment, online menus, which is alienated if we ask people to pay using online 10 years back. But now, these days, is a normal. Why is this happen? One of it because of labor shortage. Not only payment, some of the places, food service places, they replace waiter with the robots, like this. Okay? You also experience online ordering in your life. These are the sign of the issues that happen in food service, which is labor shortages. Okay? Next, the fourth issues or the last issues for today is a food service and its environmental impact. Many of us say, okay, and I already highlight to you early on my presentation that food service give a big contributor to the economy. But at the same time, we often didn't realize food service operation also contribute to the largest food waste in this world. and where this food waste goes. In Malaysia, okay, in Malaysia, all the food waste are not separated. We don't have law like Netherlands, we don't have law like Germany, which we need to segregate our food waste and non-food waste. In Malaysia, we don't have yet have that policy, so that all the food waste generated in food service, commercial and non-commercial, end up in the landfill. Okay, when this food waste goes to the landfill, then in certain period of time, it will impact our environment, such as climate changes, okay, methane gas emission, air pollution, water pollution, and so on. So these days, because of this issue, many commercial food service realize they need to do something. Okay, these are some of the alternatives or some of the option that food service, commercial food service do in order to save or to make healthier planet. For example, the waste that produced in the kitchen of commercial food service, they use it to do a stock. For example, the vegetable peeler or the bones, they didn't discard, they used to make a broth for future food preparation. And some of them use the edible but repurpose the food waste for their staff meal. And then for the non-edible, they do the composting, and this compost fertilizer they use for their garden, and then this fertilizer they use for the garden and then go back as a resources. So it's a loop or this cycle, economic cycle. So these are how they mitigate these issues in food service operation. And I think this one you already know and you aware of it because you are part of consumers. And if you ask yourself, these days, young generation, they are more health conscious. They opt for plant-based. They concerned about their environment as well. So they look for rise in lifestyle-related diet tracking tools. For example, they keep tracking their steps, okay, 10,000 steps a day, or they keep tracking how much water they consume every day, because the change of the consumer preferences will affect to food service operation, especially when you want to develop a recipe or the menu, because you need to know who are your consumers. Okay, now we move to recipe development in commercial food service, okay, for the quality. If you ask me the step is similar to non-profit or institutional food service, which the first thing first, when you want to develop the recipe, you need to ask who is your consumer, who will eat your food. This food is purposely is for who? So you need to ask this question first. Once you answer this question, for example, okay, the customer, you target youngsters who are in university students, for example. Then you ask a second question. What are ingredients available around you so that you can easily get the ingredient with a cheaper price? Okay. Next step, you combine market analysis with the ingredient selection. You do a recipe standardization. I will not repeat what Dr. Aida said. Dr. Noraida just talk about the process to make a standard recipe. You can apply that process to come up with recipe standardizations. Once done, you do sensory evaluation. What or who will assess the sensory evaluation? The first thing first, the sensory evaluation need to be done by you, because you are the one who produce it. You need to taste the the food. Okay, and then your team can be nutritionist, a chef, dietitian, and so on. And then you can do sensory evaluation by piloting your target consumers. After you receive this feedback, then you modify the menu and get the standardized recipe. After that, you send to the lab for nutritional analysis. Okay, once the nutritional analysis fit, you are okay with it, you are satisfied with it, standardized recipe also you satisfied, then you go to the next step, which is costing and yield test. Okay, costing and yield test is ask how much you need to produce. Okay, how much budget you need to produce this recipe, how much portion this recipe can give you. So you need to test it, because standard recipe only tell you, but costing and yield testing will tell you the real. Okay, and lastly, you need to come up with the quality and safety procedures such as HACCP and so on. Okay. Next is quality indicator of the recipe. You need to ask yourself, what is the quality? What is the quality of my recipe? So these are the things, these are the factors that you can use to measure the quality of your recipe. First, measure the nutritional adequacy and look at your recipe and ask yourself whether this recipe is adequate for the nutrition. Is it healthy? Is it suitable for your target customers? If yes, go next one. The quality of the recipe must be standardized. That means whoever do the recipe, whoever cook using the recipe, at any time, the output or the result are similar or same. That's a standardized. Okay. Second, ask about sensory quality. Measure the sensory quality. Is it the taste, texture, aroma, and appearance is what you expected from your recipe? Okay. Look into ingredient availability as well as preparation feasibility. Because many people say, okay, I know in my area, I have this ingredient. I think we have no problem. But when you get this ingredient back to cook it, then you realize, oh my God, my kitchen, we don't have chef to cook this menu item. We don't have experience or we don't have expertise to cook this ingredient. So therefore, other than ingredient availability, you also need to ask whether the preparation feasibility is meet or is good for your staff. All right. Then food safety compliance. This is very important, especially for the quality. You can have a good recipe, very good taste of food, but if your food safety is not complied, that's not meaningful. So food quality is one of, food safety is one of the key indicator for the quality of your recipe. And then you can use sustainability. Ask yourself whether the recipe you develop is sustained. Is it, can I use this for 10 years, for 5 years? Can it sustain? Okay. And for commercial food service, I would like to highlight again, we are money oriented. Whatever nutrition adequacy, standardization, sensory quality, whatever other indicators, the most important thing for us is money. Do this recipe that we develop can give a profit to us? Those are the key question we need to ask when we develop the recipe. And lastly, you need to test and validate your recipe to your customers so that you get their feedback. Okay, when they are satisfied with your recipe, they will do repeat orders and the plate waste data will be reduced. Right? And lastly, this one is I think this is the last slide. two last slide before conclusion. Whatever recipe development, the most important thing you need to make sure the recipe development is regularly reviewed. You need to regularly review recipe. Why? Because world are evolved. The ingredients availability may be affected. The technology also will affect your recipe. So you need to do regular recipe check. Okay, how to do it? Ask customer feedback. Do menu performances by using sales data. Check ingredient availability and cost changes, as well as embrace new technologies such as combi oven, retort, and so on. Before I end my lecture, I will wrap up my lecture with this conclusion. Commercial food service faces growing challenges. There are 4 issues that I highlighted today. First, public health, the effect on the public health, rising costs, labor shortage, and sustainability pressures. Customer expectations are evolving toward healthier, more personalized, and environmentally responsible options. Ask yourself, are you ready for this? And then recipe development is critical to improving food quality through reformulation, standardization, and innovation. Technology and nutrition expertise must work together. Remember, you cannot work in silo. Dietitian and nutrition, you cannot work only by yourself. You need to work in team with a chef, with technologies, with the policies maker, because world are evolving. It's not just evolve around you, it's evolve in everything you do. So you need to work with many people so that your recipe development, your strategies are valid. Lastly, nutrition and dietetic professionals play a vital role in shaping healthier, more sustainable food service system. I hope by knowing this, you will be a future dietitian and future nutritionist that have this concern and have this conscious, so that the world become a better place for every one of us. With that, thank you.
All right,
Pass
thank
the-
you so
yeah, I pass
much,
to Noraida.
Dr. Syafiqah,
Yeah.
for really clear explanation. So before we start the discussion sessions, we'll have a discussion session after this. But let me read some of my notes highlighting information about these 2 topics. So Dr. Aida and also Dr. Syafiqah have already mentioned about the importance of the hospital diet, and then the types of hospital diet, the meal ordering, meal distributions, and challenges in nutrition management in hospital. And also for the Dr. Syafiqah's topic, she already mentioned about the some issues regarding the topics. There are 5 issues in food service, commercial food service, which is menu labeling, that is really important for commercial food service, and also rising food costs and supply disruption, and then the labor shortages, environmental impact of food service management in commercial food service, and also changing consumer preferences, and also some of the key of risk development is to know our markets, and also doing analysis for the consumer satisfaction, and then ingredient selection and sourcing, and list of quality indicators of the recipe. So I think we have already have several questions for Dr. Aida and also Dr. Syafiqah. The first questions is from Pak Mada Agung. So the questions is, what kind of quality of food that should be considered in HIV patients in hospital setting who have candidiosis or fungal infections and have trust so that patients can consume and swallow food easily, and how to increase appetite in this kind of patients who are hospitalized. Maybe Dr. Aida would like to answer first.
Right, thank you for the question, yeah, Pak. For this patient, HIV patient in hospital setting that have candidiasis, yeah, is a oral thrush and other fungal infection. This kind of patient maybe struggling with the swallowing, susah nak menelan, right? And also leads to poor appetite. So our role is actually to provide the food that more comfort and easy to swallow while maintaining and achieving the nutritional requirement. Okay, first is to assess the ability to swallow. If patient having difficulty to swallow, then we can offer the texture modified diet. If you aware with the ITSE Despagia diet, right? We have several stages. Okay, that one we require collaboration with the speech therapist to assess the ability, which stages of the texture modified diet is tolerable and safe to our patient. Okay, so for dietetics perspective, yes, change to therapeutic for the texture modified diet, give high protein for the healing process, to improve the appetite. There are several ways for patient that having struggle with swallowing, low appetite, always offer small and frequent meal. When we offer small and frequent meal, we expect to achieve the nutrition adequacy, but patient with poor appetite, they maybe can tolerate small portion. So that's why nutrient dense food comes a big role in this patient. Okay, need to know nutrient dense food or energy dense food, and then we incorporate in their daily intake to achieve the requirement. We offer the more preference food, the favorite food, kan? And then that's the role of the caregiver lah to bring in the comfort food for the patient. Okay, so I hope I answered that question.
All right, thank you, Dr. Aida. Is that enough for Pak Made Agung, or is there any follow-up questions?
It's very enough. It's clear. Thank you so much.
Okay,
you,
thank
Pak.
you. All right. So the second questions, I think it's to Dr. Syafiqah. It's also questions from Pak Made Agung. I think in Indonesia, the menu labeling in every restaurant or cafe contains sugar information and sodium information, still not implemented in all regions, including in Yogyakarta. So is there any regulation regarding about that in Malaysia, maybe in the cafe or restaurant?
Okay, thank you for the questions. I will answer that questions. So far in Malaysia, this policy is not nationwide yet. It means bukan seluruh negara, belum satu nationwide, but implement in certain food services, especially the chain restaurants, like fast food restaurant, as well as cafeteria that have that receive by the Ministry of Health the logo with healthier choices. Okay, cafeteria with these health choices, they are required to provide calorie information for their target for their customers. We are still I'm part of the Malaysia team with the Ministry of Health in developing the policy. We are now still in the reviewing the policy, not yet implement in around Malaysia. Hopefully soon.
We hope so. Hopefully the review and the process will be done and it can be a good policy for all the regions. Okay, thank you, Dr. Syafiqah. Is that clear, Pak Made? Is there any other follow-up question for Dr. Syafiqah?
It's clear. Thank you so much, Dr. Syafiqah. Yeah.
Okay, thank you, Pak Made. So we move to the next questions. I think it's for Dr. Aida, but also Dr. Syafiqah can add the answers. The third questions is from Mbak Laila ya tadi kalau nggak salah. Okay, so it was very interesting when Dr. Aida presented about food waste at the stage of food process earlier. In Indonesia, one of the minimum service standards that must be met is unfinished meals by patient at less than 20%. I think in the presentation, Dr. Aida mentioned like 10 to 30%. And in Indonesia, it's 20%. So how is it in Malaysia? Is there any standards for food waste at the each processing stages? Because in Indonesia, we rarely calculate excess orders, overproduction, and serve but unplanned meals. Okay.
Okay, thank you for the question, Ibu. I hope Dr. Syafiqah can help me to support as well. Up to my knowledge, the food waste is acceptable range is below than 30%. But we understand that food waste is also appear throughout the process, especially starting with the purchasing until before they come up to the ward. Right, and then when the patient eat the food and then they have the waste, it also comes down to the kitchen. Right. Okay. Up to my knowledge, there are no standardized the benchmark. Okay, but it depends on the best practice among the hospitalized to set which actually the best practices for that that institution. Maybe they can review from the previous wastage. Okay, so apparently the wastage that acceptable for the kitchen is not more than 15%. Kan? And then the throughout the process in the kitchen, in the receiving and storage, whereby you receive the damage or spoiling per item upon the arrival when you do the monitoring checking, or during the preparation, maybe up to 5% acceptable range, whereby your staff is over trimming the vegetable, for example, that also lead to the wastage as well. During the tray assembly, maybe up to 3%. Okay, but to decide which number as the benchmark, you need to have the figure. And then based on that, you want to see the improvement by having the benchmark. And then that benchmark it actually can be improved based on the current progress. Okay, so Dr. Syafiqah maybe have a different thought.
Okay, thank you, Dr. Nada. Maybe I add a little bit because currently I have one PhD students who do this research in terms of food waste in hospital in Malaysia, and based on our data, first I will answer the question based on whether the 20% or 30% is our benchmark for Malaysia. I think and generally around the world less than 30%. We want less than 30% our waste. Plate waste, okay, and food waste. But the reason is hard for us to say in which process, what percentage for each process. For example, receiving what are the percentage of food waste should be maximum. We cannot say that because it's very rare, even it's hard to have a study that conducted the food waste from receiving until plate waste. And usually for dietetics studies, most of the studies focusing on plate waste. And based on the data that I reviewed together with my PhD student and Ministry of Health around 14 hospital in Malaysia, most of the waste come from plate waste. So back of the house is lesser compared to plate waste. So I think that's the reason why around the world they only set the standard for the maximum waste that acceptable on the plate waste, not the overall food waste. Do you have the data on, or maybe if Indonesia have the data, I really like to know as well how much you do like the waste at the back of the house. I mean, like from receiving until plating.
I Personally, I have not looked for the data, but as far as I know, that's one of the challenges that we have in Indonesia. So we don't have the reliable baseline data, and also the research about measuring or quantifying the food waste or maybe plate waste or the food waste from any food change process. We don't have trustable resource because it's different within it's from the community that measure that, or maybe in hospital or in household or the government itself. Yeah, it's still becoming challenges as well, I guess. But maybe Bu Nuning have already
Yeah.
looked for some information about that or have some research about that. If Bu Nuning have a comment regarding the data.
Yeah, I think that's we still don't have good data, very limited data about it. Yeah.
Okay.
Yeah.
Maybe if
Yes.
Indonesia
So,
have data, we can do a comparison
Yeah,
and
yeah.
we can set up.
Yeah,
yes.
but
Yeah.
right now we have the one project that we want to develop the proposal to measure uh, how the environmental issues from food waste from hospitals as well as from schools from lunch. Yeah, so we can gain or we can have the strategy how to reduce the plate waste from hospitals and also from school lunch program.
Yeah, that's
Yeah.
interesting.
Yeah. Yeah. So we have a future project, yeah, Bu Nuning, with the some of hospitals in our academic hospitals and also hospital in Yogyakarta and also school lunch programs running by the government. So we take samples for 15 schools in our plan. So maybe we can have some data that is trusted, at least in Yogyakarta as a baseline. Yeah,
Yeah,
we
that's good.
hopefully can do that.
I look
Or
forward.
maybe collaboration with the
Yeah,
UPM
yeah.
as well
Yeah,
in the
yeah.
future. Yeah.
Yes.
Yeah.
Thank you. I look
All
forward
right.
for it.
Yeah, hopefully we can collaborate. Thank you.
Yeah. Thank you, Bu Nuning and Dr. Syafiqah, Dr. Aida. Uh, I think we still have a couple of minutes for the discussion sessions because I think we still have two other questions. Bu Leila, is that clear for the explanation from Dr. Aida and Dr. Syafiqah, or is there any additional questions from Bu Leila? Oh, yes, already clear. Okay. So the next questions is from Bu Retno, UGM alumni. So I would like to ask Dr. Noraida about food service that uses outsourcing. Is using outsourcing more cost effective in terms of budget? And the second question is, does the service for therapeutic diets run smoothly and can be fulfilled effectively when there are diet changes? And what is the role of dietitians in hospitals in collaborating with outsourced food service?
Okay, very good question, Ibu Retno. Yeah, for the first question, adakah outsource more cost effective? I believe it's yes. If we know how to manage it, right? Not the perfect one, but it's more effective. If you see my presentation just now, the plate waste is higher for the outsourced company as compared to the in-house. Kan when we weightage the benefit and also the limitation by having the outsourced company is actually more effective because about the biaya of gaji and so on of the staff, right? Okay, that leads to more effectiveness. Okay, what Malaysia is moving towards outsource. The patient is our main priority. Okay, so I hope I answer that. Okay, that's more cost effective. But while choosing the outsource, because managing food service in the hospital is very huge responsibility. Okay, if we do it in-house, meaning that we need to have more people, more manpower to focus on the food service. But while having the outsource, meaning that our roles is very important to ensure that food produced by the outsourced company is meeting as stated in the contract, as stated in the perjanjian agreement, especially in our for patient services. If any changes on the therapeutic diet, it cannot be done immediately, but it may need some time to adjust, especially if patient, for example, just admitted after lunch hour, any changes on their diet, especially on the therapeutic meal, can be done after a day after that. Then they can receive. It takes time. Okay, that's the things that need to consider lah. Cannot make immediate changes. Okay, and then our dietitian roles in the hospital, because hospital UPM we use the outsourced company. Even starting with the hospital, we start with the outsource. So we know our roles. Okay, so our roles in the dietetic department to ensure that the outsourced company is meeting all the requirement that be preset before they sign the contract. Okay, so that's why during the tray line we do the QA. We pick the meal and we do the testing to ensure that the meal that they distribute to our patient is meeting the standard. That requires regular monitoring. Meal food tasting is our daily things that the dietitian needs to conduct. And then any things that not meeting the pre-standard, we will record in the form, and then we will penalize. Okay, so that's the rules of the dietitian in the hospital, and then versus for the outsourced company. I believe Dr. Syafiqah want to add more.
Okay. In terms of
Yes,
outsource,
please, Dr. Syafiqah.
maybe I can add in terms of plate waste. Okay. Based on our findings, regardless outsource or self, I mean like in-house, I mean like not contract, both have no significant difference in terms of plate waste generation. That's mean both produce waste more than 30%.
Yeah.
And no significant. For example, if you ask me whether, okay, if you use outsource, is the plate waste reduced? So far, in the case in Malaysia, no difference. That's additional information I can share.
All right, thank you, Dr. Syafiqah, Dr. Aida. Is that clear, Bu Retno? Okay, thank you. All right. Is there any other questions from the students? Maybe you can raise your hand and open mic is okay. We still have like 5 minutes for the Q&A session. Let me check. Okay. Maybe while waiting for another questions, I have questions. I think actually it's my personal question. So I have an interest about the Dr. Aida mentioned about the diabetic vegetarian menu in the hospital. I think that's something new that maybe not many hospitals in Indonesia have that kind of menu like diabetic vegetarian. Uh, and when I look at the presentation, the waste from vegetables is quite a lot. So how to develop the recipe that can be sustainably so can reduce the food waste, but also it can be favorably by the patients, but it's still like the diabetic vegetarian. And I think it's also for the commercial food service, maybe Dr. Syafiqah can add information about the menu of vegetarian in commercial food service that also can be sustainably but favorably by the consumers.
Wow. Very good question. That requires a lot of creativity and innovation, not only from the dietitian part, but also the role of the caregiver as well. Okay, diabetic vegetarian meaning that the protein source from that meal is come from the vegetables, meaning that the protein source is a plant-based protein, mainly from the soybeans, legumes, and all the kacang ke kacang. Yeah. The problem itself come from the vegetable portion. If you know about the diabetic, the patient on diabetic diet, they will receive double portion of the vegetables. Okay, and then the vegetables is disliked by everyone, most of the patient.
Yeah, yeah.
Maybe it leads to the menu whereby patient doesn't like the taste of the vegetables, and then maybe overcook, undercook, right? If we want to ensure patient eating that, firstly we need to know the patient is able to select lah which food that they prefer. That the main things in our hospital, we not offer meal selection. Okay, maybe in the private hospital they have the other option which vegetable
Yep,
yang
yep.
yang good lah. Okay, but if you talk about patient yang outpatient in the home setting, they have the ability to use the creativity. Usually, we ask patient to incorporate vegetable with other meals, with other protein meals. We susuk apa tu vegetable tu make it non-visible,
Yeah.
especially for the pediatric patient kan. So that's how we introduce. Okay, so I hope I answer you, Ibu.
Camouflage the shape of the vegetables. Yeah.
Yeah.
All right. Thank you, Dr. Aida. Maybe another thoughts from Dr. Syafiqah.
Okay, for commercial food service, so far we don't have a specific studies, or I didn't encounter any studies that focus on the waste in terms of uh vegetable option, because in commercial food service, plant-based is the option that requested or demand by the people. So they will eat. Whoever choose to have a vegetarian meals, then they will eat it because they are not forced to have it. So, and just I would like to share with you, I think this is similar with Indonesia. In Malaysia, those who eat or opt for vegetarian, usually they choose because of their religion. It's a
Yeah, yeah.
religion based because they are vegetarian. For example, Buddhism, Hinduism,
Yeah.
which a vegetarian is the option. So they don't have any option to eat meat. So when they go for the commercial food service, they go to the restaurant, they will order and look for this vegetarian menu. But for the Muslim, I say in general, usually we didn't opt for vegetarian because we can eat sapi, we can
Yes.
eat lamb. So maybe this is interesting as well. Maybe they have a significant difference in terms of like acceptance or eating vegetarian option between those who are like have a background religion based and those who opt to eat the vegetarian because they want to. I think they have
Yeah.
yeah, that's maybe the case.
Yeah. All right. Thank you, Dr. Syafiqah. All right. I think we have already time's up now. Yeah. So Thank you so much once again for Dr. Syafiqah and also Dr. Noraida for really interesting and insightful knowledge for us. We hope that Dr. Syafiqah and also Dr. Noraida will have another collaboration with us, like Bu Nuni have mentioned before. So thank you so much also for all the audience and the students. I hope this